Now, today is another day we are going to discuss about the anatomy of the heart, and specifically today the discussion is about the embryology of the heart. This is for the purpose of the study of ecology, echocardiogram, so that you can be able to study about echocardiogram. So we should be able to understand the anatomy of the heart, specifically the embryology, so that when you're doing echo studies of the heart, you can understand how the heart originates. This is very specifically important in pediatrics echocardiogram. So let's go straight to the point about the heart. You will see that the heart always start developing from the brain downward. See the heart start developing from the brain. So the main objectives of this study is that by the end of this lecture, everybody should be able to, number one, describe the formation, site, union, division of the heart tubes. Number two, you should be able to describe the formation and fate of the sinus venosus. You should be able to understand and describe the formation of the interatrial and the intraventricular septi. You should be able to describe the formation of the two atria and the two ventricles. You should be able to describe the partitioning of the truncus, arteriosus, and the formation of the aorta and pulmonary trunk. List and also at the last three, you should be able to list the most common cardiac abnormalities and more of congenital abnormalities, because we are dealing with the embryology. Straight to the point is that you see that the heart starts forming from the brain, and the heart tube forms from the brain, and it forms from the endoderm. The heart starts forming from the endoderm. You remember there is a mesoderm, endoderm, and so you can see the amnio, the prondio brain, the prondio, primordial part of the brain, and the not coiled part of the brain, and the endoderm. So the endoderm is the one where the heart starts developing from the brain, attached to the what is called orphalangeal membrane. Then pericardial cavity forms around that area. Then you can see the heart pump, and then the septum transverse. So the heart is obvious the first organ to functional organ to perform, to develop. It develops from the splenic mesoderm, which is a cardiogenic area from the brain, cranial to the, and which develops also to mouth and nerves, and ventral to the development of pericardial sac. You can see the heart tube. So the heart primordial is the first evident at 18 days. At 18 days, the heart primordium is evidence as an angioplastic cord which soon colonizes to form the second heart. So as the heart formed completes, the developing heart tubes lies in the ventral aspect of the embryo dorsal to the developing pericardial sac. Pericardial sac. So the orphalangeal membrane, you can see the orphalangeal membrane, you can see the pericardial tube, septum, transverse, and foregut, and the heart tube where it is. So you can see the peritoneal where it forms. Then after that one, after the formation of that one, then there's it after lateral folding of the embryo, the two heart tubes fuse together to form a single tubes fuse together to form a single endocardial heart tube, to form one single endocardial tube. So you can see how it is forming. You can see the heart cuts its. You can see the foregut developing spinal cord, or pharyngeal membrane developing forebrain, and then septum transversus and pericardial cavity surrounding the heart. So you can see the cavity is one which develops very early in life. That is, it begins to beat at 22 to 23 days. The heart starts beating at 22 to 23 days. But you remember the heart start getting felt on 18th and day. So that is how it is. So from this one, you can see that the pericardial cavity, you can see the heart forming there. You can see the heart. You can see the 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 blood flow during the heart beginning from the fourth week and can be visualized on ultrasound. So the blood flow in the heart begins on the fourth week. That is 16 months. That is 16 fourth week. That is after 1 month, and it can be visualized. It can be visualized from this scan, the fourth week. You can see that one there, an ultrasound. So the development of the heart tube is in 6 stages. The first one is after lateral folding of the embryo, the two heart tubes approach each other and fuse to form a single endocardial heart tube. They fold together with the pericardial sac. So there is fusion of two tubes occurring in the cranial counter direction. You can see what is the feet of the heart tube. You can see that is the heart tube. So now let us see what is going to happen to this heart tube. You can see the markings. Number 1 is what folds, 2 folds, 3, 4, 5, and then 6. So you can see the heart tube grows faster than the pericardial sac. The heart pericardial sac, but the heart it grows faster than it, so it shows alternate dilatation separated by 4 constriction. So it grows very fast. So these sinus venosas is number 1. They are called sinus venosas. Be very careful and see that the sinus venosas are on the lower part, and the atrium venosas is on the upper part. You see how the heart is going to rotate. So those are the sinus venosas. Then you can see the truncus arteriosas, on top there. Then you can see the bulbs cordis, Then we can see the common ventricle, which is number 4. The common ventricle. Then number 5 is the common atrium. You can see in this case the ventricle are on the lower side, but the atrium is on the upper side, but the atrium on the lower side in utero. But you'll see later on how they're going to alternate and the ventricle come down, the atrium come up. So the endocardial heart tubes has 2 ends, that is venous and sinus, that is sinus venous, and atrial end, that is truncus arteriosus. The 2, that is one is venous end and atrial end. Now, you can see how the heart is there. The ventricle is forming on the upper part, the atrium is forming on the lower side. So you can see the sinus venosus has 4 blood vessels coming there. That is the 4, they are called the inflow atrium, and you see that the atrium is on the lower side. Then you can see the valve cordis. You can see the ventricle enlarging. You can see that the outflow in the upper in the atriovenosus outflow where there is. You can see the heart is slightly bulging. So the bulbs, cordis, and the ventricle grow faster than any other organ, other region. So the heart bends upon itself, forming a U-shaped heart tube. This is called valvoventricular loop. It is called valvoventricular loop. That is how it is. This is the valvoventricular loop. After bending, you can see the sinus venosas. You can see the sinoatrial valve. There, you can see the truncus arteriosus. You can see the valves condys. You can see the primordial ventricles, and then valve condys, primordial ventricles. Then you can see the loop formation of the heart tube. So the ventricle, the atrium, the sinus, the venosus, and the barcodes, ventricles, inflow, outflow, right atrium, left atrium, ventricles, right atrium. You can see how it is forming slowly by slowly. You can see that the atrium is on the lower side, the ventricle on the upper side. You can see the sinus, venosus on the atrium. We call them, they have several, you can see them, the inflow, you can see the ventricle, you can see the valve cords, you can see the outflow, you can see the ventricle, it is bending, then you can see the ventricles, the right atrium, the left atrium, forming the ventricles. You can see now they are coming up, slowly bending up. Then you can see the right atrium, the left atrium, and the left ventricular septum, and the ventricular canal. So you can see now the heart at far end, it has already started forming something of which is common. So as the heart tube more growth is based upon itself, so the atrium and the sinus venosus becomes dorsal to the truncus arteriosus and bulbus cordis and the ventricle. By this stage, the sinus venosus has developed two lateral expansion called the two horns and the body. So venous associated with the heart development, the venous associated with heart development, you can see the placenta there, you can see the placenta, you can see the blood supply in the placenta and the venous drainage from the placenta. You can see the umbilical vein and artery there, umbilical vein and artery there. You can see the posterior cardinal vein, posterior cardinal vein. You can see the dorsal artery, a common cardinal vein. You can see the anterior cardinal vein. You can see the aortic arc 1 and 2. You can see internal carotid artery. You can see the heart where it is. You can see how it is forming the heart aortic sac. So ventral vein and ventral arteries. All these ones are the blood vessels associated in formation with the development of the heart. You can see umbilical vein, you can see the ventral vein. Each one of these one is each one of the sinus venosus receives three veins, common, cardinal, ventral, and umbilical. That is common, cardinal, and ventral umbilicals. So the cardinal vein from the fetal body, that is the ventral, form the yolk sac, umbilical from the placenta formation. The cardinal vein from the fetal body, the ventral from the yolk, and the umbilical from the placenta. Those are the three. Each receives veins from all these ones, umbilical from the yolk and from fetal body. So fate of the sinus venosus is that the oblique vein of the lateral atrium, you can see the coronary sinuses, you can see the superior vena cava, aorta, you can see pulmonary artery, oblique of the left atrium, you can see the pulmonary veins, you can see the inferior vena cava and coronary sinuses, right sinus, inferior and coronary ventricle. That is at the 5 days, that is when the heart is well and developed. So you can see at 24 weeks, it is forming the left atrium, umbilical vein, left atrium, ventral vein, common cardinal vein, and bulbous. So the right horn forms smooth posterior wall of the right atrium. The left horn and the body atrophy and form the coronary sinuses. So the left common cardinal vein forms the oblique vein of the left atrium. Okay, so can you see now the right atrium? The right atrium is open there. You can see the limbus of fossa ovalis, the limbus of fossa ovalis, the limbus of fossa ovalis, the fossa ovalis. You can see the valve of the coronary sinus, opening of the coronary sinus, valve of the inferior vena cava. You can see also the masculine pectin. So that is or the part of the left atrium. So in this the right horn of the sinus venosus forms the smooth posterior part of the right atrium, forms the smooth posterior part of the atrium. The posterior part of the atrium, this is because when the blood entering the heart requires less force. That's the reason why the posterior part of the heart is smooth. And that is where the blood enters to the heart through the superior vena cava, through the vena cava. So it has to be smooth. Okay, it has to be smooth. The fossa ovalis is the one where the foramen ovale was, so it closes and forms fossa ovalis, forms fossa. So libus of fossa ovalis, you can see the wedge of is called libus of fossa ovalis. So the right trabeculated atrial part of the right atrium is developed from the premondio common atrium. From the premondio atrium, you can see the sister terminalis. The two parts are demarcated by the sister terminalis internally and the sulcus terminalis externally. So the two are separated by that one, internal and posterior. That is the cistern, that is the one which is cristina terminalis. Okay, so the left atrium again, you can see it, the pulmonary vein, from premondio pulmonary vein, and then premondio left atrium. Then you can see part of the left atrium from the absorbed pulmonary vein tissue, the premondio left atrium, the right and left pulmonary veins, the premondio left atrium, and you can see the entrance of four pulmonary veins, smooth wall part of the left, and you can see, eh, you can see there. You can see the left atrium. So you can see the left atrium. So you can see the left atrium. So the partitioning of the primordial heart, you can see how the primordial heart separates. You can see the region of the cell dead, septum primordium, ostium primordium, and anterior endocardial cushion. You can see the septum secundum, and ostium secundum, anterior and posterior endocardial cushions fused together, and the interventricular foramen. That is the intraventricular foramen, where it was the communication between ventricles, where it is. These ones are very important because of some congenital abnormalities like um, ventricular defect and intraventricular defect. Partitioning of the intraventricular canal and also common atrium and also common ventricles. Intraventricular canal, birth codis, and it begins by the middle of fourth week. So it is completely by the end of fifth week. So, the partitioning of the atrioventricular canal, you can see the atrioventricular canal, you can see the septum primum, you can see the primordial interventricular septum, fused endocardial cushion. You can see the left atrioventricular canal, left ventricular canal, and then the foramen primum. You can see the primum. Then two endocardial cushions are formed on the dorsal and the ventricle walls of the anteroventricular canal. Two endocardial cushions are formed on the posterior, the dorsal ventricles of the anteroventricular wall, and the anteroventricular and endocardial cushions approach each other and fuse to form the septum intermedium. The septum intermedium, for the purpose of the fuse to separate to form the intermedium septum interventricular shunting. That one, you can see the septum intermedium dividing the interventricular canal into right and left canal. You can see now it is dividing it into right and left canal. These canals partly separate the primordial atrium from the primordial ventricle. Separate the primordial septum atrium from the primordial ventricle. So the partitioning of the common atrium, you can see the common atrium. Now it has started, you can see the superior vena cava, the septum primum, the right atrium, inferior vena cava. You can see the left endocardial cushion, inferior endocardial cushion. You can see the ventile, and you can see the right endocardial cushion. Is the process of common partitioning of the common atrium. So the septum primum, it is sickle-shaped that grows from the root roof of the common atrium towards the fusing endocardial cushions, septum intermedium, so it divides the common atrium into right and left half. You can see the dorsal endocardial cushions, foramen primum and septum. is separating. You can see that. Can you see that now? The atrium and the ventricle is the one which is separated first, then the right and left ventricle forms later on. So you can see the septum plenum, the two ends of the septum premium, each reach the growing endocardial cushions before its central parts. And so the septum primum bones a foramen called ostium primum. So it serves as a shunt, enabling the oxygenated blood to pass from the right to the left atrium. So the ostium primum becomes smaller and disappears as the septum primum fuses completely with the endocardial cushion, that is the septum intermedium, to form the interatrial septum. So septum secundum, you can see now the septum primum, septum secundum, you can see the septum primum. That one, they are so that they can grow and separate the right atrium and the left ventricle. You can see the pulmonary vein, so normal septum formation. So the upper part of the septum primum that is attached to the roof of the common atrium shows a gradual resorption of forming an opening called ostium secundum. You can see the ostium secundum. Another septum descends on the right side of the septum primum called septum secundum. Septum secundum, ostium, you can see septum secundum, and both of them, septum secundum, which is growing so that it can grow and form. You can see septum primum and septum secundum. So it forms an incomplete partitioning between the two atriums. So in this case, sometimes in congenital abnormalities, they may fail to completely close, and then there is a blood flowing from the right atrium to the left atrium, bringing a congenital problem. So in this one, it's very important in pediatrics echo scanning of the heart, because you see these ones not well developed. So the consequently valva of Rayleigh forms, that is called foramen of Rayleigh, the foramen of Rayleigh. So you can see the foramen of Rayleigh. So the foramen of Rayleigh, you can see the fossa of Rayleigh. That is here in a later heart, in heart where it was the foramen of Rayleigh was. You can see the valley, the rubers of dorsal valleys there. So at the back, when the lungs circulating begins, the pressure in the left atrium increases and exceeds that of the right atrium. So in this case, so the two septa oppose each other direction. So each other, its site is represented by the fossa ovalis, So at this time also, the immune mediators like prostaglandins plays a big role in the closure of these ovaries, of these foramen ovalis. So the septum primum forms the floor of the fossa ovalis. So the septum forms the ovalis, and the septum secundum forms the margin of the fossa ovalis, is called the libus ovalis. So the septum secundum forms the margins, whereas the septum primum forms the floor of the fossa ovalis. That one is very important when you're doing a pediatrics echocardiogram. So partitioning of the primordial ventricles. You can see now, let us see the primordial ventricles. Now we want to separate the ventricle into two ventricles, right and left ventricles. So let us see how they partition. Remember that we started by partitioning what? The intraventricular septum. Then we went to separate the atrium. Now we are going to separate the ventricles. So this one, the muscle part of the intraventricular septum, division of the primordial ventricles is first indicated by a medial muscular ridge, which is called primordial interventricular septum. Interventricular septum is called primordial interventricular septum. So in this case, it is a big crescent fold which has a concave upper free edges, These septum bonds a temporary connection between the two ventricles called intraventricular foramen. That is, you can see the intraventricular foramen. Okay, so in this, the intraventricular septum, you can see the intraventricular foramen in that the right ventricle, left ventricle, you can see the left atrium, that is a normal, it is a heart. Now, on the other side, you can see how this foramen is, they are forming intraventricular septum, how it is coming close. Now, the membranous part of the intraventricular septum is derived from a tissue extension from the right side of the endocardial cushion, aortic, pulmonary septum, aortic pulmonary septum, and also the muscular part of the intraventricular septum. You can see how these things are taking place. We are talking about the intraventricular septum, which is now we want to separate from the common ventricular. So now you can see that the proliferation of the inferior intraventricular cushion, the left intraventricular orifice, they are the right intraventricular orifice. So the left intraventricular orifice is on the right ventricle, the other one is on the left ventricle, and there is that canal, and then there is a proliferation so that that canal can be cushioned. So there is a membrane which comes from the tissue, from the right endocardial cushion, and also aortic pulmonary and the deep muscular part of the septum, so that it can cross this. Okay, you can see now how it is crossing. It is, you can see now the right intraventricular orifices, left intraventricular orifices. You can see muscular part of the intraventricular septum. The muscular part of it, of intraventricular septum, is closing up there, is growing there slowly. You can see that it is growing there, it is growing there, it is growing there, it is growing there. Then you can see the one it is growing there. Then the other one is membranous from the interceptor septum. It is growing like that one, so that it can cross. So the spiral aortic pulmonary septum, can see the septum groove in the truncus arteriosus and dividing into the aorta and pulmonary trunk. So now the pulmonary artery joins the left ventricle, while the aorta joins the left ventricles. You can see the truncus. So the aorta, the aortic pulmonary vein, right atrial canal, intraventricular septum, then left pulmonary artery. You can see our aorta, aortic pulmonary septum. You can see how they are growing. So the valvular cord, you can see now the intraventricular groove. You can see the aortic vesicule. It is closing up. The valvular ridge is coming up, and then you can see the other interventricular septum in its type in one, how it's closing up slowly. So in this case, the valve condition forms the smooth part, upper part of the two ventricles. Okay, in the right ventricle, it forms the conus arteriosus or infundibulum, which leads to the pulmonary trunk. Pulmonary trunk. You know that pulmonary is very important because that is where you get the oxygenated blood. So in the left ventricle, it forms the aortic vestibule, which leads to the aorta. You can see to the aorta. Now, this is something we want to see about the common anomalies in pediatrics cardiology, and you can see there is the septal defect. You can see there is a septal defect, intraventricular septal defect, and also you can see there is there is intraventricular septal defect, and also there is a septum intraseptum atrium defect in that crossing of the heart in all these portals. Okay, in this cardio you can see the septum. There is no closure in this first one, the left ventricle. You can see the left ventricle. You can see the left ventricle is having a septal defect. Is having a septal defect at this point. At this point, it's having a defect at this point. Is having a defect at this point here. Okay. Can see that defect. You can see that defect. You can see the defect at this piece. You can see the defect there. You can see the defect there. You can see the septal defect, which is common absence of septum primum and septum secundum. So the blood flows from the freely from the atrium to the other one is very common. And then absence of septum primum and septum secundum leads to common atrium. So the absence of septum secundum, and also like you can see the right atrium, the left atrium, there is nothing missing there. There is a large over foramen. Okay, excess reabsorption of the, if there is excess reabsorption of septum primum, this is because of excess stimulation of apoptosis can result to this type of problem. Patent foramen ovale, foramen ovale, if the hormones, the mediators of inflammation like prostaglandins are not produced enough, or the pressure from the right atrium is not enough to make it close, it's bring an issue. Okay, so ventricular septal defect, you can see ventricular septal defect in this H. You can see it there. Okay, so there's something called a Roger disease. Roger disease, absence of the membranous part of the intravenous septum. If the lacks usually accompanied by other cardiac defect, this type of patient always have other cardiac, and they are born with a blue baby in that part. So you can see the blood is freely coming from the left, right ventricles, from the right ventricle freely. It can result to hypertrophy, intraventricular septal defect. So tetralogy, so it is accompanied by so many overriding of the aorta, so many things happen. So Farrot tetralogy comprises of one, ventricular septal defect, pulmonary stenosis, and overriding of the aorta, and right ventricular hypertrophy. Those are the four things which are found in tetralogy of right ventricular septal defect, pulmonary stenosis, overriding of the aorta, and right ventricular hypertrophy. Because of that, and so you can see the baby is born brown, is blue, and you can see that there is that overriding of the aorta, large right ventricular. Okay, and the stenotic pulmonary tract. So there is also transportation of the great arteries, also is another common abnormalities. It can be transportation from one part to the other, pulmonary artery, panther ductus arteriosus. So is due to abnormal rotation of the malformation of the aortic pulmonary symptoms of the right ventricle joins the aorta, while the left ventricle joins the pulmonary arteries. It's one of the most common cause of cyanotic heart disease in newborn. The transposition uh, uh, um, of the great arteries. The other one is often associated with the receptor defect and the receptor defect. Okay, so persistent arteriosus, you can see truncus arteriosus is also another abnormalities where there is intraventricular septal defect, there is no closure there. So it's a problem. Truncus, you can see, so the defect there is absolutely although is due to failure of the environment of the aortic pulmonary pulmonary pyroseptum. It is usually accompanied by ventricular septal and defect, that is truncus arteriosus. Okay, so that is all about the embryology of the heart in general, and that one is very important for us to be able to scan and do echocardiogram in pediatrics children. Thank you very much for listening to this.